where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone, and welcome to the show. I'm your host, Vic Senese. Glad to have you on board. Hey, be sure to do us a favor and keep liking and subscribing to the show. Today, we got a great show ahead for you. We're diving into an exciting advancement in bladder diagnostics, ambulatory urodynamics. Traditional urodynamic studies are typically performed in a clinic setting, what I used to do. But what if we could evaluate bladder function while patients go about their normal daily activities? In this episode, I'm really happy that we're joined by Dr. Jason Kim, Director of the Women's Pelvic Health and Continence Center at Stony Brook Medicine. Dr. Kim will walk us through Glean Ambulatory Urodynamics, a technology that allows clinicians to capture real-world bladder function outside the traditional lab environment. We'll discuss how this approach may provide more accurate insights into lower urinary tract symptoms and how it works in practice, and what it means for urology providers and patients. With that, let's welcome Dr. Kim to the show. Welcome.
Hi, thanks for having me.
My pleasure. So we're all anxious to hear more about it. So I'm going to switch over to your slides and bring them up full screen and let you take it away.
Okay, today I'll be talking about Glean Urodynamics. As Vic mentioned, this is kind of one of the first innovations in urodynamics in decades, and I'm very excited to be a part of this. So multi-channel urodynamics has been the diagnostic standard for many years, and I'm sure many of you in the audience have performed urodynamics. And as you know, it involves putting a catheter in the urethra to measure bladder pressures, and then putting a catheter either into the rectum or vagina to measure abdominal pressures. And they sit in this uncomfortable chair. And this is the best we've had for many years. And it's, like I said, it's been the diagnostic standard, but it has significant limitations. So one study showed that 46% of the time, conventional urodynamics fail to reproduce patients' daily symptoms. And this is for many reasons. I know I see it all the time. I see patients that I don't think are in urinary retention. I'll check a post-void residual on the first visit and they seem fine. Then when they come to urodynamics, they're in urinary retention. Or I see patients that I know have overactive bladder, but we don't see any detrusor or overactivity. And a lot of times you have to try to make what you see on the urodynamics fit the story, and sometimes it's very difficult. Well, there are many reasons there are barriers to optimal urodynamic testing. Well, first of all, it's an artificial testing environment. Most, as you know, they come into the room, you put these catheters in. They're asked to urinate while having a catheter in their urethra and one in their rectum. And as you can imagine, I think it would be very difficult to urinate often in front of a person in this strange chair. Urodynamics is also a non-physiologic test. During the test, we typically fill the bladder at 50 to 100 cc's. This is a super physiologic rate. At that rate, we would be talking, urine production of like 3 liters to 6 liters in an hour, which is not physiologic. So it may alter what we're actually seeing. And it's also felt that the catheter presence can trigger contractions or inhibit reflexes. And lastly, it's a brief observation window. Typically, the filling portion is only limited to about 15 or 20 minutes. So it's a snapshot. And I can't tell you how many times I've done urodynamics and the patient said, well, that's not what happens to me. Well, what good is the test? And we're not really capturing what we need, and especially a patient with intermittent symptoms or isolated nighttime symptoms. I have a whole cohort of younger women who seem to have a severe frequency right before bed. I've never been able to capture what's going on with urodynamics in those patients. And so there are also significant resource and infrastructure challenges to conventional urodynamics. There's a high capital expenditure needed. Most of the machines, urodynamic machines, cost $40,000 to $100,000. They required a special room, dedicated space that's often larger than a regular urodynamics room. And this is unjustifiable for many smaller practices that do limited testing. And also requires expensive yearly service contracts. I know for a conventional urodynamics machine in our practice, I think the yearly service contract is about $5,000 a year. And additionally, these machines, I think they usually have a lifetime of about 7-8 years, at which time companies stop supporting them. They tell you the computers are outdated and you'd have to buy a new machine. And in this economic environment, a lot of hospitals don't want to pay for this, especially with declining reimbursement for urodynamics. And another big one where I think maybe many members in your audience can sympathize with is special training requirements. A good urodynamics nurse is a gem, and they are extremely difficult to find. I know the traditional urodynamics companies put on a weekend course, or they'll send people to your office to train urodynamics nurses. Well, however, it's not so easy, and quality control is often an issue, staff turnover, and it really can threaten the test quality and consistency. One of my old residents in Michigan tells me she's in a practice. They have 2 sites that do urodynamics. Their very experienced urodynamics nurse retired about 3 years ago, and they just haven't been able to find anyone to fill that position. And for 3 years, their expensive machine, the equipment in a specialized room have been sitting empty. So staffing is often a huge concern. I know in my practice, I have a very good experienced urodynamics nurse, but she comes from a large family, and every year her siblings go to the Jersey Shore for like 2 weeks of vacation. And traditionally in the past, we've had to stop urodynamic testing because we had no one that could fill in. So these are some of the challenges with staffing. And all these issues lead to limited access and scheduling, and patient wait times are drawn out, and they get frustrated and may delay surgeries. So let's talk about ambulatory urodynamics, a new approach. And so as we spoke, conventional urodynamics has significant limitations. And this ambulatory monitoring may offer a solution. It measures bladder pressures in natural environments and captures true patterns during daily activities. So what is the evidence base for ambulatory urodynamics? Well, ambulatory urodynamics, the concepts I think started first in maybe the 80s. And basically they were just miniaturized conventional urodynamics machines that still needed catheters in the urethra and the rectum. But they were machines that the patients could take home with them and hopefully get more data in a more natural environment, in the ambulatory environment. And even then, they found that there was an improved diagnostic yield. They found that some studies showed that, for example, in patients with overactive bladder, we found detrusor overactivity 60% of the time as opposed to 40% of the time with conventional urodynamics. And they also found a change of diagnosis in 37% of patients. And this is still the machines that have the catheters and everything. So just the fact of taking it out of the office and into the home and ambulatory setting, it changed diagnosis a significant amount of the time. They also found there was better symptom correlation, links symptoms directly to pressures patterns using real-time markers, and led to higher diagnostic confidence and better treatment selection, and reduced the need for repeat testing. And it was good for physiologic conditions. It could replicate real-life conditions, natural bladder filling, daily activities, eliminated a lot of the test-related anxiety from trying to urinate in that room in front of people. And it provided an extended window for monitoring. Well, if we knew this since the 80s, why did ambulatory urodynamics never achieve wide adoption? I think the main thing was catheter dependence. It's very uncomfortable to have these catheters in all the time. So I don't think patients wanted it, have catheters in their urethra and rectum overnight or longer. It was complex equipment. There was a lot of fiddling with it, and people are experienced with urodynamics. You understand that you have to fiddle with the machine a lot of times. Can you imagine patients having to do that at home? There was an infection risk from prolonged catheterization. And of course, what drives medicine a lot of the time are reimbursement barriers. There was no pathway for compensation with this in the past. Well, things have changed significantly. Recently, the Glean Urodynamics system was FDA cleared. It was cleared, I believe, in April of last year. It's a completely wireless system. There's no external wires. It's catheter free. There's no catheters during testing. It's easy to use. It simplifies a workroom. You can do this in any room in your office. You don't need the specialized setups, and that's probably one of the most attractive features. So The Glean urodynamics system has multiple components. So the first thing is a bladder sensor. This is a disposable sensor that's deployed in the bladder during the duration of the test. It measures bladder pressures and records it on the device. And once you remove the device, it has Bluetooth capability, so it gets downloaded to a clinician iPad. We have a Bluetooth-enabled Uroflow machine for pressure flow analysis. And there's a whole software package. So in the room, we have a clinician iPad where all the data gets downloaded to. And there's also a patient app. And the patient can download this app on their phone, and they can record events such as urinary leakage, urgency, things like that, or voiding during the test, which can be correlated with the pressure data. And so what happens here is all the data is synchronized into the Glean ecosystem. So, for example, in the beginning, we might get a Uroflow. So the patient goes to the Uroflow, that data is synced to the clinician app. The bladder sensor is then deployed, and when it's removed, the data is synced to the clinician app. The patient has an app where they can denote sensations or leakage or voiding, and that is sent to the web app. All this data is put into the cloud, and then there's a web portal, and it'll give you the report with all this data integrated. It's really nice. Now, one question we often get is, my patients are older, they can't use an app on their phone. Well, Glean has thought about that. One of the things that they've offered is, instead of the patient app, they actually have a paper diary. And I don't know about you guys, but I've always found voiding diaries and paper diaries, they're very hard to read and interpret, and I really don't like doing that. Glean is taking care of that for you. They have a specialized diary that you put on their pad, and when the patient comes back with the clinician app, you can take a picture of it, and it's all integrated into the report through AI, so you don't have to weed through it. So if we look at conventional versus Glean urodynamics, there's a real paradigm shift. So the testing environment, as I mentioned, conventional urodynamics needs a dedicated suite, specialized equipment, and a trained technician. Glean can be performed in any exam room, anytime, by any trained clinician. And honestly, when we say any trained clinician, it's anyone who could put in a catheter. I know rules vary by state. I'm in New York State, and the MAs cannot put in catheters. The LPNs can put in catheters. So we regularly have our LPN now doing Glean urodynamics. I think in states where MAs can put in catheters, they can do the Glean urodynamics. The in-room time is cut significantly. On average, there's a 60 to 90 minute duration of a urodynamics test, so you have limited capacity. For Glean, it's about 20 to 30 minutes set up in the room, and then the patient can continue with their normal activities, and later in the day, they come and the device is removed. It's essentially like a stent on a string. It comes right out. We've doubled our capacity to do urodynamics in a single day since we've started Glean. Let's talk about the learning curve. Traditional urodynamics, there's extensive training, complex troubleshooting. Oftentimes the studies the quality isn't great when you can't recognize problems during the testing. I'll have some examples of that later. With Glean, it's all automated. The device is inserted to the bladder, and there's automatic quality checks, and there's intuitive software. The patient experience. Oftentimes with conventional urodynamics, patients have significant anxiety, discomfort. 36% may show voiding failure, and this kind of limits the usefulness of the test. With Glean, there's privacy, it's catheter-free, natural activities, and increased voiding success. And the capital investment, as I mentioned, urodynamics machines are very expensive. Glean has a low upfront cost, and so it's much easier to utilize in offices. Capital investment will not be a limiting issue for Glean urodynamics. The most expensive component is the Uroflow. So what we like to say is the urodynamic suite now fits in your hand. I mean, on the left, we could see the traditional urodynamic setup, and I'm sure we're all familiar with that chair and everything. Now this bladder sensor essentially takes it all over. Okay. This is an animation of the Glean. This is a sheath. It's backloaded. This is how we deploy it to the bladder. It essentially looks like a coude catheter that's put into the bladder, and it is pushed with a pusher. This is very easy to do. On average now, it takes me probably less than 10 seconds to do. There's two sizes. There's a longer one for males and a shorter one for females. Once it's deployed, the bladder is allowed to fill naturally, and we usually have a couple voiding cycles before we take it out. The patients will return later in the day, and the device will be removed, essentially like a stent on a string. It's no harder than removing a stent on a string. The data is then downloaded along with the patient's data on the app. You simply push a button and it activates the Bluetooth. Data is downloaded. All right, so let's talk about some of the studies. I was lucky enough to lead the clinical trial for the FDA approval, and this was a prospective single-arm study. We called it the MUSE study, Modern Urodynamic System Efficacy, and participants underwent standard urodynamic testing followed by Glean testing. We completed the testing in 32 patients at multiple centers. We were unable to place a sensor in one patient due to an unrecognized bladder contracture. But this is akin to, I'm sure you've seen this during regular dynamics. You try to put in the catheter on occasion, you can't get it in because of an unrecognized urethral stricture, bladder neck contracture. And really, there were no serious adverse events in this study. They were on par with traditional urodynamics, things as transient dysuria, transient hematuria, things like that. And what did we find? We found that the Glean system is easy to use and enables voiding. We found that during the study, 82% of the clinicians inserting the device found it easy to insert, easy or very easy. The removal, 97% rated was easy or very easy. And 100% of our patients were able to void with the Glean in place. And this is interesting because we had started with conventional urodynamics. And we had 5 patients that looked like they had acontractile detrusors and were in urinary retention. However, after we put Glean in and allowed them ambulatory filling, they were able to urinate. I think this highlights some of the artificial environment of testing, and I think this is one of the powers of Glean. Then we assess the patient experience, and I'll just highlight a few of the important findings here. The patients felt that filling of the bladder was more comfortable with Glean, 71 to 45%. And then we asked patients who had the conventional followed by Glean, which did they prefer? And patients overwhelmingly preferred the Glean urodynamics, the conventional urodynamics, by almost 2 to 1. But actually, what surprised me more was that male patients actually really found Glean to be a lot more comfortable than females. I thought it would have been females. Females still prefer Glean, but it was the male patients that found conventional Glean urodynamics a lot less uncomfortable. And then there's this concept of net promoter score, which I was unfamiliar with. I think it's used a lot in marketing. They looked at the people who would support the test, tell their friends and family to get the test or do it again, and those who wouldn't, and they subtract those two numbers. What we found was conventional urodynamics had a negative promoter score, which means the patients didn't like the test. They wouldn't recommend their family and friends get it, while Glean urodynamics had a positive score, which meant patients didn't mind the test and they wouldn't discourage their friends and family when getting it. So there's significant differences here. So this is just a primer of the Glean workflow. When the patients come in, we insert the sensor. It's backloaded to the sheath like a coude catheter with a pusher. And once the device is placed in, we get a few what we call provocative maneuvers. We ask the patient to cough and to Valsalva. And we also typically get a pressure flow analysis or uroflow analysis and post-void residual. Now, these events are really important because traditional urodynamics was multi-channel. This is only a single channel bladder pressure, and a lot of, if you're used to regular urodynamics, you're saying, I need a bladder pressure, I need abdominal pressure. However, what we found is once you learn to read Glean, is it absolutely necessary? No, we can read a lot without the abdominal pressure. But that's why when in the beginning, the provocative maneuvers such as a cough and Valsalva acts as a key to events for later, and I'll show you what I mean. Once the device is inserted, we do physiologic monitoring. And depending on the question I have, I may ask the patient, why don't you go out for a couple hours or come back in 4 hours, 6 hours, depending on how long I want monitoring. I live in the suburbs, so many of my patients are quite close to the office. So I'll say, go home, just do your normal activities and come back. Typically, I'll put in the morning and tell them to come back after lunch. And during this period, they document events such as urinary urgency, leakage, voiding with their app or on the paper diary. Then they come later in the day, we remove the sensor and we download the data, and the data is fed and into the cloud, and our web portal will spit out the report. Now, one thing I will mention is oftentimes I put in the morning and take it in the afternoon, but there's sometimes where I want information overnight. And I will actually put it in the afternoon and tell them to come back the next morning. And so we can capture overnight events, which I think is another power. We've never been able to do this with traditional urodynamics. I'm just going to go over some examples of the tracings here. This is just a brief introduction to what the tracings look like. I've actually, on behalf of Glean, I've prepared an hour-long video on how to read Glean tracing. So if anyone has the interest, they can go to the website and watch that video. So in this example, we have a male in his 60s. He has a 60-gram prostate. His chief complaint are lower urinary tract symptoms. And we use a Glean workflow, and we want to answer, how well does this patient's bladder work? I think we were considering bladder outlet surgery, but before we committed to it, we want to know if the patient had his symptoms due to BPH or whether his bladder just didn't work. Now, this is just an example of what the kind of tracings you'll get from urodynamics, from Glean urodynamics. Now, let's look at the bottom tracing. This is the entire duration of the test. So this test to me looks like it was put in probably about 8:30 a.m. and it was taken out maybe about 4 p.m. So that's a pretty long test, almost 7 to 8 hours. Now, if we look, those who are experienced with urodynamics, you might look at the bottom tracing and say, oh, there's a lot of coughing or Valsalva type events. Well, you have to reframe how you think about it a little, because this is 8 hours compressed into one tracing. But what we actually do is on the right side where it says minutes, what we see is we've typed in 6. So this is a 6-minute window. So you can customize that window and look closer up. And what you can see on the bottom left tracing, there's a yellow box. So the 6-minute window refers to that box. And we could go ahead by 6 minutes or whatever we set. But I highlighted the first 6 minutes to show you what the beginning of the test looks like. So the 6-minute window is expanded on the top. And you can see the device is deployed, and then you can see the red C. That's where we ask the patient to cough. And we can see that the patient coughed, and you can see the typical kind of cough pattern, about 120 centimeters of bladder pressure. We then ask the patient to Valsalva, and similarly, we see what looks like a typical Valsalva to about 90 centimeters of water. We then ask the patient to urinate, and the green and the blue are the pressure flow analysis. So the green is actually the flow, and the blue is avoided volume. Now, this is a static picture. In the app, if you hovered over any of this, it'll give you the pressure and the volume in real time, along with the cough and the Valsalva pressure. So one thing we have to look at is, I think we're so used to looking at typical urodynamic tracings, you might say, well, that's a continuous curve and looks good. But if we look at the axis of the flow for the green, on the right side, the peak flow is only about 4 cc's, which we know is a poor flow. And the patient urinated about 130 cc's. And towards the right side, we see a green P. If we hovered over that, which they're doing here, we see that the PV is 94 cc's. But we see when the patient urinates, if we look at the tracing on top, we actually do see there's an increase in bladder pressure to about 120 centimeters of water. And you could see this pressure looks distinctly different than the reference events of cough and Valsalva. And this would indicate a contraction of the bladder. So we see that the patient's bladder contracts quite well, but the patient has a poor urinary flow. And that's kind of classic for a high pressure, low flow, which would be indicative of an enlarged prostate. Now, I've zoomed in an 8-minute window later. So if we look at the bottom tracing, if we were to think about conventional urodynamics, we might just say that looks like a valsalva or something like that. But when we look at an expanded view, what do we see? The patient, there's a V for void. And we see the patient, when he voids, his bladder generates pressure up to about 120 cc's again. And this is in the ambulatory phase, so we don't have volume data here at home and so forth. But how do we know that's a void? Well, here I've put on the side the beginning part where we did the provocative maneuvers, and we can see the left side what the contour of the bladder pressure change looked like when he voided. And let's look at the pattern later on. They look remarkably similar. So we could conclude that this is a bladder pressure related to a void. And again, he's generating very high pressures. So in this case, I think we could confidently conclude that the patient is likely obstructed. We don't have abdominal pressures. We still can do it. Now, I just want to highlight one other quick example. This is a patient that came in to me, a 75-year-old female. Her presenting complaints were difficulty urinating, incomplete bladder emptying. So this was a urodynamic study performed by community urologists. I believe this is one of those urodynamics that was outsourced to another company, and they came in. And based on this reading, the urologist diagnosed the patient with urinary retention. The treatment plan was intermittent catheterization and off-label tamsulosin. The patient did not feel comfortable with this, so she came to me for a second opinion. I know this tracing is a little difficult to read, but what do I see? This tracing is problematic from the beginning. If we look at the abdominal pressure line in the beginning, it starts to rise, and instead of kind of addressing the issue, the technician appears to just zero out the catheter so it'll go away. And it appears that happened several times. And in the middle, it seems like we lost abdominal pressure kind of towards the middle. I don't know if the rectal catheter fell out or what, but it's very difficult to tell what's going on here. And this is often what we see when we get referrals with urodynamics. This is an example of a poor quality test that we can't really draw conclusions from. Well, she came in and I said, we need to repeat the Glean urodynamics. And so we did. And again, the bottom line here is the whole test duration, which I think was, we did this overnight from about 4 p.m. till 10 the next morning. If we look at this is the first 30 minutes, we see that when the patient came in, we asked her to urinate, and the blue and green is the first uroflow PVR. And the patient actually did urinate with a peak flow of about 13 cc's per second, and she urinated about 200 cc's. Her PVR was not significant. And then we did our provocative maneuvers, which you could see a little past half with the red C, the cough, and her Valsalva. It wasn't great. But we asked her to urinate again, and she again urinated with a peak flow about 12 cc's, and she urinated about 130 cc's. And she did generate some detrusor pressure here, and her PVR is minimal. But now at this point, we sent her home overnight and told her to come back in the morning. What do we see? This is interesting because we were looking for urinary retention, but I zoomed in on a 30-minute window here a little after 6 p.m. What do we see here? So the L in the middle denotes leakage. We see 2 spikes here that go up to very high pressures. These are more consistent with detrusor overactivity. So in reality, this patient has urgency incontinence, and it's very clearly seen from this test. I think this is the power of ambulatory monitoring. And there's no doubt about it here. So these are examples of tracings. We have more in-depth videos, as I said, if you want to look at tracings. So let's talk about Glean's current scope and consideration. Really, it enhances your dynamic assessment, but we have to understand there are some limitations right now. Currently, there's no abdominal pressure sensor or channel. And as you can see, if you're experienced, you can read tracings pretty confidently without it. But if you need it, then Glean is not for you. There's no EMG. I find most of us use patch electrodes, and the quality of the EMG is poor. And half the time, if it confirms what we think, great. But when it doesn't, we kind of ignore it. So if you absolutely need an EMG, then you can't do Glean. and clinical expertise remains key. One of the things is we're not advocating that Glean take over all urodynamics, but there are a lot of patients who it works well for. To me, like BPH patients, if you want to know if they have bladder pressure, the woman who comes in and says, I just leak all the time, and you can't tell whether it's urgency incontinence, stress urinary incontinence, or overflow incontinence, things like that. However, we said there's no abdominal pressure, but in Q2 of this year, so shortly, we expect them to release a rectal suppository that you can put there. Again, it's on a string that can measure abdominal pressure. So now we will have true multi-channel urodynamics. What is my workflow? I usually schedule 3 to 4 patients in the morning. They come in with a comfortably full bladder. Depending on the clinical condition, I may consider cystoscopy. I also like to do cystoscopy same day because it ensures that the bladder is full during the test. We deploy the Glean device, we get our reference events, and we do a pressure flow analysis. Then we ask them to go home, go shopping, do their normal activities, come back later in the day. They have their bladder diary where they record all the events. When they come back, we remove the device, download the data, and we typically schedule a telemedicine visit to review the findings. And the nice thing is there's a flexible workflow. It can be tailored to your practice. You can do a short test and a longer test. And so some people for BPH just put it in with a full bladder and they ask the patient to urinate and they can see whether they generate bladder pressures or not. Now, how has it transformed the Stony Brook urology practice? We're a large academic practice. We have 9 clinical sites. 7 of the 9, 2 of the sites are pediatric only. So really we have 7 adult sites. In the past, we only could offer urodynamics at our 2 main locations, which is a main urology site and our dedicated women's pelvic health and continence center. Many of our other sites are smaller sites, satellite sites with maybe rented space from a primary care physician. And the capital expenses, the staff, and the room needs prevented us from having full urodynamics programs. So it was like a hub and spoke model where people would have to travel sometimes the eastern end locations. It would take patients an hour and a half to get to our office. Well, since we started doing Glean, we now offer it. We've increased our urodynamic capacity 3-fold. We're now at 6 of 7 adult sites, and soon our 7th adult site will adopt Glean. So it's really transformed how we do things. It's better for our system, it's better for patients, and gives us better results. So I think it wins in all aspects. And just to finish up, we're going to talk about what's next in the pipeline for Glean. Well, during the ambulatory phase, we can see bladder pressure, but we can't see how full the bladder volume is. The next iteration of the device will have integrated volume sensing. So we will know how full the bladder is. They put 4 light sensors on. They're able to extrapolate the bladder volumes at any given time. I also think in the future, there'll be automatic interpretation. We know for EKGs, for example, you do the EKG and oftentimes there's that automated reading. I know they tell us never to trust that reading and read the EKG yourself, but let's be honest, I'm a urologist. I rarely look at EKG, so I'm highly dependent on that reading. I do think in the future, you'll have automated readings for urodynamics, and they're working on extended battery life. Currently, the data has to be downloaded within 24 hours, but I do think in the future, they may have a battery last several days, maybe a week. To me, this would be perfect pre and post percutaneous nerve evaluation for things like sacral neuromodulation, put it before and after. It'll help automate voiding diaries, especially with all the new WISER audits from Medicare. I think this could be a game changer. So I'm going to stop there and I'll take any questions. Thank you very much.
Well, that was fantastic. Feel free to put any questions in the comment box. Just blows my mind to think that they can come up with these sensors so small and to have, 2-channel urodynamics is really a great plus. I do have a couple questions right off here. How is the post-void residual calculated? Because you showed that.
So, we still use a traditional machine for that.
So just
we would with any other paper. You could do it with a catheter. In our practice, we always we have the machine.
Yeah. Okay. That's was kind of wondering this device come up with some miracles, but I didn't think it could do that.
Well, in the future, it might with the volume sensing. So
yeah, that's interesting.
First generation device. The next device is if it gets sense of volume, it may be able to figure out how much is in there, how much actually gets urinated out. They're constantly making refinements on this.
Yeah, I can see. Another question that I had was, how does ambulatory urodynamics compare financially with traditional office
Yeah.
urodynamics? And
Okay.
looking at equipment, staffing, all that.
Okay. Well, so look, uh, that's a great question. Currently, we're using two of the four traditional urodynamics codes. We have the 51728, 51729, and the complex uroflow code. We cannot use the abdominal pressure code, which we could in the near future when the suppository device is approved, and the EMG we're not capturing. Now, the device, the sensor is more expensive than the traditional disposables for conventional urodynamics, right?
Hmm.
And so a lot of offices say, well, this doesn't make sense to me. Our profit margin is less. But they're not factoring in the capital costs of the equipment, the service contracts, the need for trained staff, the need for the specialized room, and most importantly, the time to do a study. So what we found is we can reliably do twice as many studies in a day as conventional urodynamics. And urodynamics is often the bottleneck before surgery. Or I run into a lot of BPH guys who say, I would love to get urodynamics, but it's such a pain that I just forego it. Well, now you can add this. And so one thing I didn't mention is in the map, you saw we've basically tripled our urodynamics capacity. So our main center used to be really backed up with urodynamics. Now I just need to do it in the morning and I have more than enough visits because a lot of it is being offloaded to other sites. So on a per study basis, your profit margin is less, but you have to factor in all the other things. In this day and age, how many hospital systems want to buy a $100,000 urodynamics machine every 6 to 7 years? You have to factor those kind of considerations in.
Yeah. And I think you made a key point that you need somebody who's trained to do these to get a good result. You just can't have anybody. You can teach anybody how to put a catheter in, but I don't think you can teach anybody how to do urodynamics because you need to know that neurobiology to know what you're looking for.
Yep, exactly. We get a lot of kind of poor quality tests because people aren't appropriately trained.
Yeah. So then it's just a waste of money for that fact.
And by the way, I didn't mention it's Stony Brook Urology. We're an academic level 1 site. We've shifted 90% of our urodynamics to Glean.
Yeah, I believe it.
Yeah,
and I can see where there's maybe you could discuss what cases would you not do Glean for?
So if I need video urodynamics, like a lot of the bad neurogenic bladders, I would get conventional urodynamics. If I really want
spinal cord injury,
and honestly, like if I need an EMG, and a lot of times spinal cord injury, you want an EMG, then I would get traditional urodynamics. So,
and look, as you said, that wouldn't be a sticker EMG; that would be needles.
Yes, yeah, right. Yeah.
For anyone who's ever done urodynamics, having those pads on doesn't give you really good readings. It's reading too much. So.
Right. They get wet and they just look completely active. You can't tell what's going on.
Exactly. I did get a question here from Janelle. I'm sorry, urogyne nurse here. How could this apply to patients with vaginal prolapse who need pessary reduction? Oh, that's a good one.
Yeah, it's no different. I mean, so the difference is it really isn't any different. You put the device in with the pessary, without the pessary, you tell them to go home and see if they leak or not. I mean, it really doesn't change things. I mean, during conventional urodynamics, you're reducing prolapse to see if there's leakage, for example, stress incontinence. Well, put a pessary in them and tell them to come back in a few hours. You're going to get the same answer.
Yeah, exactly. I see there was another question that I had here. Oh yeah, I remember. The maximum time this device can stay in.
Yeah. Okay. Well, the data has to be downloaded within 24 hours.
So that's just a battery issue.
Yeah. Well, so I think the device shuts off at 24 hours. If for some reason it goes past 24 hours, you don't lose the data, but you would have to send it back. Okay. To the company, and they could get the data for you. I do want to make one point of clarification. The current FDA labeling, it says ambulatory urodynamics up to 24 hours. There's some debate whether overnight, I think technically if you put in overnight, it's considered an off-label use. But that being said, I'm doing it. I know a lot of clinicians are doing it because it makes total sense, right? But they are working on studies to get that validated right now.
So ideally, you're looking at like a 8-hour snapshot.
Yeah, well, but some places are doing 40-minute tests like BPH. If they have a full bladder, you put it in,
Mhm.
you get the study, you can see whether they're generating bladder pressures or not. So it really depends on what question you have.
Yeah,
So
that's a good
that's
point.
another nice thing. You tailor the study to what you want, what you're looking for.
Yeah. And Susie Swain asks, can the device cause bladder irritation?
That's a great question. The predicate device was something called UroMonitor. It was developed by Cleveland Clinic and Bright Urolicense Technology. They found that it really didn't cause significant irritations. That being said, I do find that some of my patients feel it, but like no more than traditional urodynamics catheters. I've heard from
Absolutely.
women that oftentimes it feels like they have a tampon in. And interestingly enough, men seem to tolerate it better than women. And I do find women with really bad OAB, it might be irritating to them, but so are traditional urodynamics catheters.
Yeah. And I think the one thing that we sometimes neglect to think about is the fact that when you're trying to do urodynamics in an office setting, you've got people there watching you, and it's very, no matter what you try to do,
Yeah,
it's hard to simulate a normal environment.
right, exactly.
And I was always on the area where sometimes you worry about somebody standing up to void and getting a vagal response and they pass out. So you're kind of leery about leaving them alone to void with all these sensors in. I've had it happen a few times.
Yeah, we've had it happen more than a few times.
I think this is just going to be phenomenal. As I mentioned, I was really glad to get somebody in when I saw this at the SUNA conference. I'm like, this was the way to do urodynamics.
Yes,
to get more information.
And look, it's a new product. They're constantly making refinements. I think in a few years, it's really when it has automated reads, volume sensing, extended battery life. It's going to be a game changer. I think, to me, just thinking of it, there's so many avenues that can open up. Inpatient in the hospital, we get all these consults for post-op urinary retention. And half the time the question is, can you do urodynamics in the hospital? And the answer is no, we don't have the machine. I see a world in the future where you can pop the device in and get some more answers.
Yeah, exactly. Are you familiar with the device called Proud P?
I am. I don't have experience with it. That's a app-enabled sound
Euroflow.
Yeah. I've heard about it, and I've seen it. I've seen that's validated. I don't have much experience with it. I think I know where you're going with this. So one of the things,
it would be a perfect match with the Glean.
Right. So actually, Glean they have they're probably going to release soon at home Uroflow. I think it's a mesh-based device that you put over the toilet seat. So I know they're doing apps and different devices. I'm not sure which is better than the other.
Yeah, it's all good, because now you've got, again, other devices that can be recorded anytime you urinate. They just take out their phone. It doesn't work for women. It only works for men.
I think what's great is you could do it at home in the comfort in a more natural setting. That's the whole point, whether it be a device, an app, or whatever.
Yep. All right. Do have a couple more comments that came in. Hello. Thank you for working to make urodynamics more patient and performer friendly.
Yeah. Look, this is one of the best things, I think, for this. It really gives the patients more dignity, allows them to urinate at home or in privacy. So I'm very excited about this.
And I think you answered this one. Have you used it with women with bladder prolapse and found it to be equal to traditional urodynamic testing?
Yes.
So long as you reduce the prolapse and get your test results, it's going to be very similar.
Oh, one thing I didn't mention is I find I don't know the background of the nurses here. The urologists, we tend to go below Valsalva leak point pressures, which are very easy to measure with this. The gyne-based urogynes tend to use UPPs. And you can get a UPP with this. Instead of just pulling it out, you have to pull it out a little more slowly, and you can get a UPP. So if anyone gets that, then we can do that too.
Wow, that's great. All right, I don't see any other questions. It's a fantastic talk. I really appreciate you coming on the show. It's been great to have all this information, and I think that we really will make our practice much better to, for patient friendly and much better for practitioner friendly. And I think, again, it takes a little bit of that learning curve out of having to train people when you can, trust a little bit more with the computer doing some of this work.
Right.
So that's really good.
And for anyone in the audience, if they're interested about learning more, please reach out to the company. They're very proactive in talking to interested clinicians. And a lot of times they will even connect you with me if you have more kind of clinical questions.
Yeah. Great. All right. I have a little promotion I'm going to share with everyone for next week's program.
Kidney stones can be one of the most painful urologic conditions patients experience. UroNurse will stream Crushing It, slam dunk strategies for managing kidney stones from Chicago Metro SUNA Spring Conference. Dr. Jeremy Lai shares practical, evidence-based approaches for diagnosing, treating and preventing kidney stones in clinical practice. March 14th, urology professionals gather to discuss the latest advancements in urologic care, stone management, and patient education. Dr. Lai discusses modern strategies that help healthcare providers better manage kidney stone patients, including clinical evaluation, treatment options, and prevention strategies that can improve long-term outcomes. Join us at 9:30 a.m. Central Time to learn more.
Yeah, so next week we're having our urology convention conference with our local chapter, Chicago Metro SUNA, and we will be broadcasting one of those talks that starts at 9:30. You can tune in at 9 o'clock. We'll have some stuff going on beforehand, but join us for that conference coming to you live. Well, Jason, it's been a pleasure having you on the show. Any last thoughts?
Thank you.
All right, great. Hope to get you on a future show because I'd like to talk about some of those other devices with you.
Sure. I'm always happy to talk. Just shoot me some emails. A little busy right now, but maybe in a couple months.
That's all right. We're here all the time, every Saturday at 9 a.m. Central Time.
Okay.
All right, everybody. We'll have a great weekend, and we'll see everybody.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.